is take you through a journey of really what we've tried to do here at the University of Cincinnati and the emergency department, and branching into other areas within the health system briefly. But really, I want to talk about, how this started and the difference that I really truly believe we're making. The basic objectives, more for just objectives, but there's going to be a lot to talk about. Understanding the state of OUD kind of at the state and local levels. I use this data as part of an educational program. Also indicates partnerships. Recognize the challenge of educating the staff, and really the disease model of addiction. Getting over that stigma when we have about 150, 160 care providers within the department, and that's just APP's residents and attendings. The third would be to describe what the EIP model for public health and its role, and how we've incorporated substance use disorder into that EIP model. EIP stands for Early Intervention Program, and we'll talk more about that. The protocol development, and throwing in some how it's got to be a team concept. It's certainly not an individual, it is a large team. And then look at some of the data we've had since the inception of the program, a little over a year, and how we use that for drivers of change. So this slide goes out to 2019. The data is not complete, but it's Hamilton County, and that's where the University of Cincinnati resides. And it's deaths due to the unintentional overdoses between 2008, really beginning of 19. And you can see that, the numbers really peaked in 2017 and have slowly come down. But we're going to see a little bump. We'll see that in a graph in just a second here. It's broken down into type of medications. Obviously, there's polypharmacy with a lot of these overdose deaths. But it gives us an idea of where we are in the county. This slide is kind of a humbling slide. It really is telling us that if you look in June of 2020, and I had mentioned in an earlier webinar that in May we saw our numbers go up for ED visits and EMS volume. Well, June followed really strong. The mortality data is not in yet for those. Really, May, June, and July are not complete. But you can see that 356 911 dispatches in the county, and that includes within the county the city of Cincinnati and the city of Norwood. And you can also see that the number of ED visits is really at a level that we haven't seen for 16, 17, 18 months. And that it could be a reflection certainly of COVID, new drug on the street, etc. I've talked to our needle exchange personnel, and they really don't have a good feeling of why. I mean, they can all say COVID. Unfortunately, a lot of the people that they had been seeing, they're not seeing coming back in the numbers they thought they would. They are seeing some old timers come back, however. So just the numbers are not, all going down. There are certainly some that are going up, and this is obviously being closely trended. I'd say over the last, not including this past week, we saw numbers between 10 and 15 overdoses in the county per day. And over the last several days, we've seen that number come down to 6 or 7. So it's coming down again, but it's interesting how there is fluctuation. There was also a large fentanyl bust here in the tri-state last week. This is interesting because we follow overdoses by geocodes. So it's really not where the overdose occurs. It's where the patient resides, and we follow. But what's interesting, it's not in surprising areas of Hamilton County. If you look, dead center, the bright red, where there's a number 2, number 13. Those are areas of what we call Price Hill, and that's a very high area of overdose, and is well publicized in books, etc. That's where they're interviewing people. And why is that important? Because resources are sent to those areas that may not have been sent if we didn't have hotspots where we could actually mobilize people to. And we're actually setting up a office type building for the needle exchange in that Price Hill area based on geocoding here. So is it getting better? Well, between 2016 and 2017, per the CDC, Ohio as a whole has seen looking at overdose death rates, heroin is down almost 32%. So something is working. And certainly programs like we heard about a couple weeks ago up in Akron, and what we're going to hear about in Cincinnati, certainly are a small part of that. But needle exchanges, fentanyl test strips, all these programs that are going on, and we can't lie, the ORs and how we prescribe medications, the collaboratives many of our health systems are on with the Ohio Hospital Association, looking at prescribing practices of every physician within these health systems, and just beginning to feed back that information to them is it's very, very powerful. A couple things, as we go through this data, I was just reading actually yesterday that the AMA came out and said that 40 states reported an increase in opioid related mortality this year. And the CDC came out with a report for 2019 that greater than 72,000 people died from overdoses, which is a new peak in annual deaths in the United States. And New York Times kind of followed what the AMA says, but as of July 15th, drug deaths so far in 2020 have increased 13% compared to the previous year. So, although this number here shows it's going down, and some of the county data that I shared shows that the overdoses are going down, the reality is that in the last several months, it's going back up. This is a article that was recently published, and it talked about the emergency department clinicians' attitudes toward OUD and the use of buprenorphine. And I kind of highlighted the three big conclusions. 80% of the respondents agreed that buprenorphine should be administered in the ED, but only 44% felt that they were prepared to discuss the medication for MAT. And compared to clinicians that with fewer than 5 years of practice, those with greater experience were less likely to approve of ED-initiated buprenorphine. And I think there's some generational gaps, which we're going to talk about, the stigma and education and educating a wide variety of providers, and certainly a difference in age. And finally, most physicians said that buprenorphine-based intervention ED would be feasible with institutional support, including training opportunities, protocol support within the electronic health record, counseling and support staff, and a robust referral system for outpatient follow-up. And as we talk about the program that we've set up here in Cincinnati, it's I just saw this last week, and really it's very true that all these in the pinkish red are very critical to how we were able to start the program without even seeing this. This is basically the challenges we came upon. This is a article from Gail D'Onofrio out of Yale, who we heard a couple weeks ago also is really like kind of the landmark study that kind of pushed us ED physicians to get things moving a little bit. But it relates to COVID and basically saying, there are reforms needed both nationally and locally and within the emergency department in order to continue to move forward, because this is not going away. Something that I heard was that COVID-19 is a pandemic upon an epidemic. So it's really layers of burden and layers of challenge upon those that are really truly suffering from substance use disorder, including, of course, opioid use disorder. So it's certainly impacting our patients. There is no doubt. So this slide here, it may not make sense, but to me it makes a lot of sense, and it's really what I really want to talk about of educating a faculty of 60 plus physicians. We have about 30 advanced practice providers and 56 residents. And to start a program here, I really felt like we needed a lot of education. And so I came and just said, we do a great job taking care of diseases, diabetes, hypertension, asthma, all that. But a lot of those diseases that we see in addiction, abscesses, cellulitis, boy, spinal abscesses, endocarditis, things that I hadn't seen in the first 20 years of my career, is let's treat the disease that actually caused this, the disease that the patient presents most of the time to the emergency department for. So I really, really say it's great that we can take care of the cellulitis, but they're going to have cellulitis again if we don't take care of the disease that really caused or led to the disease that they present to the emergency department for. So I know we all on this call know all this, but as part of the education program, I really wanted to emphasize, the cardinal features of substance use disorder as it being a often chronic relapsing brain disease. Because the chronic, often relapsing brain disease, we see that in the emergency department. Or the patients that present, a lot of them they're not necessarily frequent flyers, but it's not the first time that they're there with a complication from shooting up or overdosing. And the compulsive drug seeking, use despite harmful consequences, and genetic and social environmental stuff is all involved with this. I bring it back to the ED because when I educate, it's really important for me to try to help people understand that when people overdose or shoot up and then develop complications, that is not a choice, okay? For most people, the majority are not choosing to die or not choosing to get cellulitis. The majority are not choosing to lose their families and their careers. So it's a disease of the brain. It's taken over the brain, just like a disease of diabetes or hypertension is taken over those organs where they don't function properly. Cravings for the drug is important when I started to educate because, in a way, a lot of these patients we see in the ED that have not just been or going through withdrawal, but they're craving the drug. Addicts, when they're active in addiction, once again, I know you all know this, but as an educational program, they're not thinking about doing their kids' homework. They may be thinking about it, but in the back of their mind is that obsessive thinking about the drug. It totally controls those with addictions, their mind and what they're thinking about. Their inhibitory control for efforts to refrain are gone. And we go through the biochemistry, which I'm not going to do here, of addiction, just like we would if we were talking about diabetes or hypertension or asthma. So I think the cardinal features of the SUD, although pretty obvious to us, when we break them down to the type of patients we're seeing in the ED, trying to get everybody to understand, the whole choice. Is there a choice? Is there some chemical disbalance? I think that's really important. So how I really like, to keep things very simple. So when we talk about the misconceptions, moral versus the disease, we can talk about moral. It's a choice. It's weak self-will. And that's what, emergency medicine had done for many, many years. Especially, I'm part of that during my career is the treat and street model. Joe's back with his alcoholism, or this is, Jane's 20th relapse from heroin or fentanyl. The treat and street model. Basically, here's a sheet of paper. If you even get that, stop doing that, etc. It's beyond that, and that's that disease model. And this disease of addiction, it is most of the time activated by a choice, even if that choice is a physician giving a patient a Percocet prescription for a broken arm. The patient still has a choice to take it or not to take it. There wasn't, I would imagine back 15, 20 years ago, there wasn't a lot of education around opioid addiction and better alternatives for drugs. But the disease is activated by a choice. Cancers, people smoke, diabetes, people eat their donuts, etc. But nobody that I know of says, boy, I woke up and today I'm going to decide to be an addict. Dr. Volkow has published widely on this. New England Journal, this one's from 2016, talking about the misconceptions regarding opioids and addiction. And they just asked a bunch of providers, what's your feeling? And the reference is there, but like addiction is the same as physical dependence and tolerance. Only patients with certain characteristics become addicts. Long-term use is the only way you can become an addict. So a lot of these things that were thought and perceived needed to be, there needed to be education around those also. So this slide here, once again, keeping it simple. I know this audience is a lot more, knows a lot more than just keeping it simple when you're trying to educate 150 people that really have not had much addiction training. But, and this is how I approach every single patient that when I initially see them or deal with them in the emergency department and families. And it's the one we all know, is simple: disease of diabetes. That, people don't say, I'm going to be a diabetic today, but there's a medication that can help you, insulin. There's pills that can help you for diabetes, but you also have to have some behavioral therapy, some education around that. Like, you can't hang out at Dunkin' Donuts anymore. And I say to those with addiction, you have a brain disease, and your brain and dopamine aren't getting along, and they're kind of out of whack. But we have a medication that can, once again, simplifying, help the dopamine in your brain, and it's going to keep you from hopefully craving and withdrawing. But that's part of it, getting you help and getting you into things that I find incredibly important are boundaries and things like recovery and learning about how to live healthy. And Alcoholics Anonymous, Narcotics Anonymous, I truly believe that those programs, even 10 years out into recovery, are programs that help remind us how to live life. Life as an addict, but also life if you're not an addict. The principles of AA are incredibly important. So this trial here, it's a little dated. It's from 2000. And it's a relatively interesting read because it talks about relapse rates in general for different diseases. And this is not just opioids. It's a bunch of different drugs. But it's defined as not taking your medications as you're supposed to take them, or not following a treatment plan. And like with diabetes, they follow the A1Cs, they talk to the patients, but it's 50% across the board for drug addiction, diabetes, type 1, and hypertension, and asthma. And that's an important thing when we say, well, do we judge patients that come in with their fourth episode of hyperglycemia or DKA, asthma, or they're back getting another treatment? No, at least I'm not judging those patients. I really look back and I never had judged those patients with any moral stigma. With addiction and alcohol use disorder and all, there was a part in my career that treat and street model, not proud to say, was part of how I practiced, and to be honest, how I was trained. Not forcefully trained that way. That was just a practice pattern. So this has all changed and leads us to really what we're here to talk about. And that's our medication for opioid use disorder program here in Cincinnati, and CEC is our Center of Emergency Care. And it basically follows roughly a SBIRT type model. It's screened. I think it's important that we talk about EPIC. EPIC is what most hospitals, at least in this area, and I think in Ohio, are using for a medical record system. It's called EPIC. And EPIC, we built a program within EPIC to screen patients for opioid, not substance, but really opioid use disorder, looking at past history in their charts that are documented, looking at risk factors for infectious disease, looking at what medications they're on, looking at previous discharge diagnoses, looking at previous chief complaints, all in the background of EPIC. And that's done in seconds. So by the time a patient comes back, EPIC has notified our early intervention program team, which we will talk about, that, oh my goodness, there's a patient in room 14 that is screened positive. Okay, that's one of the ways we screen. By the way, the nurse in triage asked one question about opioids and said, have you ever used an opioid for a non-medical, have you ever used a non-prescribed opioid for a non-medical reason? And if the answer is yes, that sends a second screen to our early intervention team. That's like you got to go see that patient because they've screened positive twice. We also have an early intervention program team that includes, and we'll talk about these, addiction counselors. There's 2 of them, and they're on the webinar with us today. Health advocates and peers are all part of our program in the emergency department. And then looking at EPIC, screening the board, walking in the patient's room that screen positive by just looking at EPIC, and also through the EPIC alert. And of course, the ED care providers have been trained to really look, and when everything's missed based on initial screening, if there's more to the history, our ED care providers are much more in tune now to use the resources in the emergency department to help that patient potentially enter recovery. We do provide MOUD education to these patients. We do have counseling through our addiction counselors. We can talk more about that. But ultimately, a big part of this is medication. And so when I educated our staff, I had to tell them we're not really treating opiate use disorders. We're not really doing inductions in the emergency department. You don't need to be able to administer buprenorphine with you don't have to have an X waiver. You can just write an order for it in the emergency department if you're using it to treat cravings and withdrawals. So no matter if you're X waivered or not, in the providers that we educate, we train them that we are treating the withdrawal of these patients and cravings, allowing them the opportunity to meet with our counselors, not be in withdrawal, and get into recovery. Those that are X-waivered, when we start prescribing and maybe doing a home induction and getting them followed up, that's when we go into the OUD area of the program. So the MOUD program really is a withdrawal and craving program, but we'll talk about how we have X-waiver docs in our program. And referral to treatment, we refer to treatment, and we guarantee that a patient will not leave our emergency department without a follow-up within 24 hours with one of our partners here in Cincinnati. What works is evidence-based treatment. It's buprenorphine. I do educate about the affinity difference between fentanyl and buprenorphine, and how it's important to understand the difference of the affinity being so high for buprenorphine because of the precipitated withdrawal. I talked about the difference between administer and prescribing, but there's a bullet point there that says hospital policy revision, because no matter what the Fed said or the state said, we had a policy in the hospital, the whole health system, that the only people that could prescribe or administer buprenorphine were those that were part of psychiatry and addiction sciences. So that was a stumbling block that we had to basically convince the health system when we started to move forward that the ED and really all other areas of the hospital needed to be able to administer this medication. I'm not going to go over this. This is Dr. Dorofio's study from Yale, but basically 80% of patients that were treated with buprenorphine and did have a brief intervention referral were still in treatment at 30 days, compared to about 40 to 45%. In addition, there were less illicit opioid use in the previous 7 days for the patients that did receive buprenorphine, and also that ED visits decreased when the patients were started on buprenorphine for recidivism to the ED. So what is the early intervention program? Because this is key to our pathway. It started about 20 years ago with infectious disease and hepatitis C and HIV. About 20 months ago, we integrated the substance use portion of public health into this. And currently we're undergoing a major $19 million COVID public health initiative through a grant to increase testing in the populations that are vulnerable, and that will be our patients in addiction. So it's right now a patient presents to the emergency department if they are asked, basically a nurse asks a question for risk factors for HIV and hepatitis C, and if they get a affirmative response, that patient's automatically tested. It's an opt-out where they'll get an HIV and hepatitis C, and an EIP in the health department then follows those. We're similar with the COVID-19, hopefully. The SUD is not opt-out. We screen and we identify and we approach those patients. Basically, the EIP team's goal is to improve health and healthcare utilization. We use proactive responses to these health threats, and we integrate into the healthcare, the community, and other public health resources within our community, partnering with the needle exchange, very active in programs such as that. That's just one example. We serve and we link patients to care through screening. We have health promotion advocates that are on the team. And we interact with very diverse, disadvantaged, and a very still stigmatized patient population and trained to do so in a very culturally competent way. So our EIP team, the substance use disorder arm of this early intervention program, um, includes health promotion advocates. So we've got two full-time people that are awesome that basically screen patients in the ED for the psychosocial conditions and their underlying needs, and they talk to them. We'll talk about the social determinants of health and how their disease is impacted by those social determinants, and talk about housing, etc. We seek to intervene with education. There's some behavioral counseling that we all go through. There's certain very basic techniques, but we also start talking about referral to resources. It's a step criteria. We have our addiction counselors. We have two addiction counselors. They're Tracy and Kim. They're on the phone today. One, they're licensed addiction social worker, supervisor at LICDC, very highly qualified, and we are so blessed to have them as part of our program. They help with the advanced assistance related to the SUD. It's a much more intensive evaluation. It identifies the SUD treatment needs, basically following that ASEM criteria for the treatment continuum. Best place, best med, thus what's the best initial linkage to care that we will arrange so they have an appointment within 24 hours, 7 days a week. They provide sustained assistance over the weeks or even months following the initial ED encounter. Follow-up phone calls are a big part of this. How can we help? This is, even as an inpatient, we've been involved with the patients. I want to comment on that UC is blessed to be one of the few academic health centers that I've been told in the United States that has a comprehensive inpatient addiction consult team with addictionologists, a physician, soon to have or now have social workers and peers as part of that team. They are very busy consulting on the patients that are admitted, and most of them do come through the emergency department. So anybody who is identified with a substance use disorder that is admitted to the hospital does have an inpatient consult to the addiction science team. So the ED peers are also an incredibly important part of our program. I've listed some of the things that we try to encourage with our peers: inspire hope, share experience, their strength, to listen, using their peer experience to understand, provide empathy. Because when these patients are laying on a gurney getting IV antibiotics in an ED that's holding 50 patients, you got 60 in the lobby. They're there for quite a bit of time, 4 to 6 hours at the minimum, oftentimes days in the emergency department. To have a peer there that can keep them engaged during that time is incredibly, incredibly important. Making a follow-up phone calls, also keeping track, once again, an important part of our program. For education, I'm not going to go through the COW score, but the COW score is was part of the education for all the providers, because it is an important part of our pathway. As we all know, once you get some experience doing this, and Dr. DiNorfio at Yale, she looks at the COW score and goes, yeah, it's part of our protocol too, but we don't use it. When a patient's in withdrawal, look at them, take their pulse, and they won't be sitting in their chair. It's very true, but when we have 150 people that will be interacting at some point with these patients, I still like to objectify using one of the scales available, and we use the COWS scale. So this is the pathway, and it looks pretty complicated, and it's not. The neat thing about this pathway, we talked about screening being integrated into our computer system, EPIC. Well, this is also integrated into EPIC. It's part of a secondary program called Agile MD, and we use it for abdominal pain and COVID. But as you go along, you click on, it's not highlighted, they're in different colors. This is not. But you can click if you wanted to call you start right at the top, patients with possible OUD. You can consult the unit clerk to get a hold of our EIP team. The phone numbers are there. As you scan down, is the patient craving, enter in withdrawal, and we put a caution if naloxone is received within the last 12 hours. When we first started the program, that was a contraindication, but through literature and through conferences such as this, we're going to follow the science of the medications, and Narcan's not there for 12 hours. So at what point is the withdrawal no longer due to Narcan? When is it due to the actual drug in system? And obviously they're not having drug in system. So we have caution due to precipitated withdrawal, but if it's 2, 3, 4 hours and they're still in the ED and they're with the patient says, I feel like I'm withdrawal, and they do the COW score, and they're interested, we will treat them sooner than 12 hours. If there's no interest in MAT after being seen by the team that we discussed, the promotion advocates, the peers, the counselors, all you have to do is click on those medications to the right for the supportive care, and those are automatically ordered within Epic. So the doc doesn't have to go, searching for those drug medications. They would be automatically entered by clicking. If they are interested, education has already been performed, and their COWS is less than 8, we will wait until they are ready. But if their COWS is greater than 8, they receive buprenorphine. We have 4 to 8 milligrams, and that's basically based on package inserts. We have looked at this. We have studied this. We have reviewed every patient that really has gotten buprenorphine, and the most effective dose in the ED where we find their COW scores go below 8. I'm not saying most effective dose for their treatment of opioid use disorder, but for their acute treatment for cravings and withdrawal, it's 8 milligrams regardless, as long as the COWS is greater than 8. So if the caveat that I had originally put in, is consider if the COWS is greater than 13, use 8. By word of mouth, we have changed that to, probably just start with 8 milligrams of the buprenorphine. And by the way, you can see it's just buprenorphine. We're not using combination product because it's administered in the ED, and staff has also been trained to stay in the room for the minimum of 3 minutes after administration to make sure it stays in mouth. So after 45 minutes, we reassess the COWS and we redose. We have a semi-arbitrary limit of 16 milligrams. I know when we're in the OUD arena that the state says without being an addiction counselor or being board certified, actually not addiction counselor, a psychiatrist, or board certified in addiction medicine, here in Ohio, you need permission from one of those types of providers in order to go above 16 milligrams. So I'm just trying to keep everybody out of trouble, but I have gone above 16, especially when we're dealing with a precipitated withdrawal. So ultimately, you keep giving it until their COWS is less than 8 and you've maxed out on 16 milligrams. And then you are referred to treatment. And the EIP team, the counselors, the promotion advocates help here and get them into a provider within 24 hours. Referral options include the Talbot Engagement Center, which is an inpatient unit right across the street from us. We here at UC have an addiction science division. It has its own separate building that has a methadone program on the first floor and has Vivitrol, buprenorphine, and dual diagnosis on the second floor. Brightview is a large private recovery organization that the founding physician, Dr. Sean Ryan, he was a mentee of mine here at UC, and also had a great interest in this and had a great business interest, and took this and left emergency medicine to run one of the largest, if not the largest in Ohio, private recovery centers. The CAT House, as we call it, the Center for Addiction Treatment, is a inpatient and outpatient facility that we have a close working relationship with. So the comfort meds are shown. When those that are waivered and want to do a home induction, we provide a home induction sheet, which is there in color for our patients on how to continue what had started in the ED. We have information for our team when our counselors are not there, addiction counselors. We do have EIP team members 24/7, but if they're busy, we also train the providers. Here are our immediate partners, which we have agreements with, the Brightview, Talbot, Cat House, and Addiction Sciences, that will guarantee follow-up within 24 hours. And we have printouts to explain how that's done. So it's great. That rare time that a patient may say, well, I'm not ready, but I've got social determinants are preventing me from going in 24 hours. We educate toward the 72-hour rule. which is basically they can present to the ED one time per day for 3 days, and we can redose them. But the majority of our providers are waivered. So of the APPs, advanced practice providers, and emergency physicians, the N is about 95. And right now there's 69 of those providers are ex-waivered. So there is never a time that we will not have a provider in the ED that is not ex-waivered that can help out for those patients that would require a prescription until they can reach their scheduled appointment. We talked about precipitated withdrawal. So I have 3 stars at the very end, additional bupe until withdrawal abates. I've given out my phone, I'm not giving my phone number out here for the entire state, but I locally, you know, if there's a problem 24/7, even if I'm working clinically, I will make time to help our providers help that patient. So I want to talk about really quickly the program and how it started, because that's really the program. And I'm going to show you some data, but how did this all start? Well, honestly, as I told and I've mentioned on this before, I've been in recovery for nearly 10 years, but really, we know it's just today. And I have a passion for the last 10 years because I know I wasn't doing the best job I could as a physician for many years. And so I had a passion to give back to those that I really thought I understand what the disease of addiction and the choices, quote, choices people are making, but they're really not making those choices. It's this disease that is just overtaking your brain. So I had an idea that, you know, we should do more, and then it turned into we can do more. And so it's really important for any program, but the way this program developed, I came out as a champion for we need to do this, okay? It's starting to, you know, with Gail's, Dr. Norofio's study in Yale, it's we need to do more. And so I got to meet the medical director for an addiction science division that, guess what, it's been there for a long time, but I didn't even know it existed. And so we started to build these incredible relationships amongst divisions and departments. So we had some clinical champions both in the ED and outside the emergency department that were passionate to providing those with substance use disorder better care and an opportunity for earlier recovery. So with the clinical champions, there were 2 or 3 of us at that time. We went and said, we're going to meet with the dean of the College of Medicine. We're going to meet with the CEO of the health system, the CFO, the chief operating officer, the psychiatry department chairwoman, along with myself and the addiction science leaders. We all met in one room, and we said, you know what? We've got a bad epidemic, okay? And it's called addiction and opioid use disorder and overdose and, you know, all this stuff. And everybody shook their head saying, we have a problem. But there's nothing that they were going to invest in that program. And I was absolutely beyond angry, but acceptance is a big part of my life. And I said, okay, we're not going to get the resources like EIP, like I talked about, but we're going to start this program. And we started educating, we started changing policy within the hospital and laid the foundation for like the pathway that you saw well before any funding was put into the program. Ironically, and through, you know, divine intervention, all of a sudden there's some major grant money around this for the health system. And they had to pick projects that would fit the needs of this large grant through the state of Ohio. We're talking a $39 million per year grant. And of course, one of the 3 projects that were chosen was, oh, we know this guy, Rick Ryan, who's really pretty passionate, along with a bunch of other team members. Let's use their project because it meets one of the arms that this grant was asking for. And with that, we were able to obtain 2 addiction counselors, you know, peer support, health promotion advocates, data personnel, to really start this program. And so the program was started bare bones, and we were going to do buprenorphine and MAT with or without funding. but funding became available. And once funding became available, we had to figure out a way to make this sustainable. And being sustainable is what we're hoping through our addiction counselors that we have in the ED and the partnerships we have built with addiction sciences is that our counselors on day 2, after they meet on day 1 and do a part 1 assessment in the ED on day 1, that's a long assessment and the patients are willing to stay. On day 2, they will see our addiction counselor will go over to addiction sciences, do the part 2 assessment, and continue with physician MAT or MOUD treatment as indicated, whether it's methadone, buprenorphine, or whatever. So it's an integrated program that allows a patient, if they are willing, to enter recovery in the ED. We were able to bill on the second day of that recovery. We can't bill in the ED for the addiction counselor, but the sustainability is when they show up on day 2 when we can drop a bill. And that is the goal, and eventually merge our counselors into actually group meetings for just ED patients. So we have lofty goals. We're on our way. So here's the data. It shows since inception in November of 18, those that have been treated with buprenorphine are in blue. Those that are discharged from the emergency department with a opioid-related diagnosis or a chief complaint around opioids is in orange. The percent of patients that are treated with MAT between the blue and the orange is the gray. And I arbitrarily set 50% is our goal. That's an arbitrary number, if anybody knows of a real number. But I'm saying a lot of those patients why it's not 100%, well, many of the patients that have OUD or overdose, they don't want treatment, they elope, etc. So there's reasons why. But if you look at the numbers, really COVID began to hit February, March, and in February, March, really February, is the first time we had our full team together. We had our addiction counselors were in the ED, our healthcare promotion advocates were in the ED, our peers were in the ED. We had integration with our addiction sciences, and we treated 98% of the patients that were eligible. I'm like, oh my God, this program actually works. That when I say eligible, I had a diagnosis or a chief complaint around opioids. And then all of a sudden, guess what? Our team didn't fall apart, but they were kind of furloughed. And they were kind of told they can't go in certain parts of the ED because we separated our ED into COVID, non-COVID, et cetera. And you see the numbers started to drop over March, April. But if you can start to see going into June, and I don't have the July data on this graph, but it's even higher, is that the patients are coming back and we're treating more patients. So that is just raw data in a graph form. This is our sister hospital, which is more of a community hospital. We have the MOUD program out there. We have a social worker out there that does basically all social work, but has an interest in addiction. We don't have our full EIP team out there right now, but are beginning to send resources out there. So we are still seeing patients and treating patients with buprenorphine in that community setting. The percentage of patients that are referred to actually go to addiction sciences in 7 days, we have an appointment in addiction sciences arranged within 24 hours. That's not a problem. But the metrics for that grant that I had mentioned are 7 days. So that's what we use, is they've got to be there within 7 days. And you can see the percentage of patients that are referred. It can be anywhere from 0 to 70% actually show up within 70 days. And these are just patients that receive buprenorphine. Our team is seeing all the other patients that aren't receiving buprenorphine. They're seeing patients that have substance use disorder, alcohol, benzos, you name it, we're seeing it. So this is just the opioid data. And then this last slide just shows how the progression and how the numbers of providers that are ex-waivered is up to 69. And that we've had programs that have been brought in back when they would pay providers to actually show up and get CME for free. We had 3 of those programs. We've had online trainings for the ex-waivers. So anyway, so the number continues to go up, which is, I find absolutely remarkable at the amount of buy-in. And it truly humbles me that the group has really taking this with such a passion. So really quickly, key take-home points are clinical champions early, identifying and integrating existing programs within the health systems like addiction sciences, collaborating between stakeholders, your community partners, both short and long-term partners, and try to build in sustainability into a grant-funded model. But it doesn't need to be grant-funded. Education around the disease model of addiction is so important to build buy-in. And then, of course, my mantra is, hey guys, let's treat the disease that's caused this disease that we're seeing the patient in the ED for. And this is really important. And it's amazing. This happened to me again last night at a community hospital. Is why. I can't tell you how many times, and these are 3 patients. I'm going to add the 4th one, but that just I can remember who they are. Thank you for caring. You know, saying this directly to myself as an emergency physician. Thank you for not judging me. Thank you for understanding. I can't tell you how much that means to me that a patient sees that we care about their disease of addiction in the emergency department setting. Patient last night broke down in tears and said, I can't believe finally somebody cares and understands what's going on with me and offering me help for my, and she was there not because she was, in, CAL score of 26. She was there for another medical related reason. I don't get too many thank yous. And I'm sure my ED colleagues don't get very many thank yous for treating asthma, hypertension, and diabetes. But if you ask, I bet they get these same thank you for caring, thank you for not judging, and thank you for understanding. So with that, that's pretty much it. That's our program at UC.
Well,